So it's a great pleasure to be here at ASRS in Montreal. I'm Aleksandra Rachitskaya. I'm a retina specialist and I practice at Cleveland Clinic Eye Institute in Cleveland, Ohio. So our study is unique because it was analysis of DAVIO 2, which is a phase 2 study. And what we did, we took the eligibility criteria for the current studies that are phase 3 and applied them to phase 2. And what we wanted to see, if we use that eligibility criteria, what did the outcome look like in terms of vision and anatomy, and also we looked at the supplemental treatments. And what we saw is that when you apply the criteria, the eligibility criteria from phase 3 LUGANO and LUCIA trials, that you see the sustained outcomes in terms of vision and also in terms of anatomy. So I think it's actually really important to understand the difference between anti-VEGF and TKI, or tyrosine kinase inhibitors. And EYP-1901 is a bioerodible insert that's done with intravitreal injection, and it allows for sustained release of tyrosine kinase inhibitor vorolanib. And it's supposed to act in the eye for at least 6 months. Now, when we think of our currently available anti-VEGF treatments, we think of VEGF suppression. The way that TKIs work, they actually work inside the cells, intracellular, and vorolanib provides suppression of VEGF, PDGF, as well as IL-6. So you have this approach intracellular with multiple mechanisms. So DAVIO 2 is the phase 2 trial, and we have a very robust data set. And so we wanted to see if we took the eligibility criteria from the current phase 3 trials and apply it to the patients in DAVIO 2, what the results would look like. So this was a post hoc analysis of the patients in DAVIO 2. So it was actually encouraging to see that when we applied that criteria and looked at the DAVIO 2 patients, we saw this sustained outcomes when it came to both vision and anatomic outcomes. So when we applied the phase 3 supplemental criteria to our phase 2 patients, we saw that actually there was less requirements for supplemental criteria because they're different in looking at those patients. So once again, it kind of provides a little bit more evidence as we move forward with phase 3 trials. So I think it's hard, obviously, to say from this information. We're very excited to see what phase 3 results are going to show. But I think it's encouraging to see this type of trends when we take, our phase 3 eligibility criteria and apply it to our phase 2 trial, when we look at vision outcome, supplemental treatments, and anatomy. But I think it's, it's impossible yet at this point to say what exactly phase 3 is going to look like. So what I'm excited about when it comes to TKI is that it's totally different mechanism of action. And we talked how it's intracellular, you have this pan inhibition of VEGF. And so it's going to be very interesting as we learn more from LUGANO and LUCIA, and there's other TKIs that are currently being investigated, kind of to understand what does it mean in terms of providing best care of our patients. We have amazing treatment. Anti-VEGFs work really well, but we do know that some patients you can't extend, even on whatever the newest anti-VEGF is. And also, we also know that there is this, even with repeat treatment, some patients don't follow up, and our real-world outcomes are never the same as in the clinical trials. And so potentially providing this sustained release will allow us to give durability and support the visual outcomes for our patients. So I think it's going to be very interesting to see those results, and I think they're going to inform us actually obviously if TKIs work, but also how to potentially, if TKIs do become available for us in clinical practice, how to integrate them into our clinical practice. Because like we mentioned, they're not meant to replace anti-VEGF, and how do these medications work together? I think that's something we're going to learn as well. So I think unfortunately we still have patients that require there's a high burden of treatment. And as great as anti-VEGF is, there's some patients that I think we're not able to provide the durability, and we still don't get to the visual outcomes that we potentially could get to. So I'm excited about TKIs. I think like I mentioned, it's a new mechanism of action. It's a different approach. So we'll see. There's a lot of data that is going to be coming out in the next several months. So stay tuned, and I think we'll all learn together. I think AI is such a broad term, right? If you think about it, I mean, we use AI now, even in small kind of ways. I think AI could be really helpful for us to take care of the patients in clinical practice, to take away the things that you don't necessarily need to spend time as a physician and focus on real interaction with patients. I think that also another great utility of AI could be in patient selection, let's say for clinical trials, right? Or going through the charts and identifying potential patients. So I think it's something that we can definitely use to provide better care for our patients. I think we all need to be cognizant of AI and the big things that we always worry about. How do you train AI? And especially if you do research involving AI, you need to make sure that you train it on the patients populations that we do treat, right? That it's inclusive and includes the heterogeneous populations that we treat in our clinics. But I think AI is definitely the way of the future, and it's up to us to really be cognizant how to utilize it.